Yes, we can see you and your slides both,
Right.
and we can
Okay,
listen you.
good. So thank you for the opportunity. It's been a while since I've heard and seen so many friendly faces and people that we share lots of memories with. When Afsar spoke to me, he said we could either present a case or give a talk. So I thought I'll give a talk and finish with kind of a nice little case for discussion before I say what I did with the case. But I think the first talk has kind of covered most of what I've got in my talk. But I'll just go through it because dealing with calcium nowadays is becoming really quite very, very prevalent. Everybody needs to be familiar with how to deal with calcium. So I kind of called it the role of atherectomy devices in PCI. So I'm just giving a quick, brief overview about what we have and what we do and the current devices, what's on the horizon. Of course, the new devices, they might not be new as such because now they've been on the market for a while. Then I'll show you a quick case. So, of course, this has been mentioned. We are dealing with more aging population, diabetes, renal disease. There's a lot of complex and calcified disease. And of course, if you don't treat the calcium, you don't prepare the artery well. So the suboptimal result will end with stent under expansion, which in turn will lead to stent restenosis and thrombosis, and maybe even more dire outcome, even death. So this is just from our data, a little old, but has not changed even up till now. The BSIS database shows us that now we're dealing with a huge number of patients who are above 80. And of course, when somebody is above 80, no matter what, even if they don't have too many risk factors, you do not expect their arteries to be just smooth and nice. Yeah, every once in a while you might have one, but the majority of them will have complex disease and will have lots of calcium. So why do you need to modify the calcium? Of course, because that will facilitate the procedure itself, because it will allow you to deliver and get access to the lesion very well. And the black modification also will make it much simpler to deal because it changes the compliance and minimizes the vessel trauma and create more and larger MLD, which allows you to deliver bigger stent and to make sure that it is expanded very well. And of course, we know that it has been shown to improve late outcome by eliminating the stent under expansion and the stent and opposition. So there has been a meta-analysis. I'm just going to show you this quickly. And we know that if you prepare the lesion very well, you are always going to have a better outcome. So what do we have? We have multiple options, and they have been covered a little bit earlier, from the cutting balloon to the scoring balloon to rotablation, laser, orbital atherectomy right now. And of course, IVL has become very, very prevalent because it's an easy equipment to use. It's a balloon like anybody else, anything that we use on a day-to-day basis, except it's a little bit more bulky, so that makes it a little bit difficult sometimes to deliver. And of course, you'll be familiar now that they have changed, the new balloon has come out in the market, and we've been using it now for a couple months, which is a little, gives you 120 pulses rather than 80. So how do you think about, if you think about the available devices in two acronym, makes life much easier to remember: the roll and the non-roll. The non-roll, like the non-compliant balloon, cutting balloon, scoring balloon, high pressure balloons, which is like the OPN, and the roll one, the rotational atherectomy, orbital atherectomy, lithotripsy, and excimer laser. So it kind of gives you an idea what exactly the equipment that you use on a day-to-day basis. So if we go through these one by one, rotablation, I'm not gonna breach. You all know it and you all see it. And I heard there's 8 centers, I understood, in Pakistan use it. But it is really one of the most significant and most helpful devices that we can have to deal with calcium. It's been on the market since 1986 and has not changed, apart from introducing the Rota Pro, which is a hand control rather than having the foot control. And of course, it does work by differential cutting, where it only cuts the hard tissue and kind of deflect the soft tissue, and also by orthogonal displacement, which is the rotation effect. You could see how it modifies the lesion. If you look at the lower, the right-hand side, post-rotablation, it's nice and clean and shaved in comparison to post-PTCA, which everything's ripped and everything dissected. Does that make a difference? Of course it does to a certain degree, but quite often this is what you get with the rotablation, because it produces more smooth lumen, which improve hemodynamic flow. Now, The new one is the orbital atherectomy. I'm not sure if it is available in Pakistan or not. I have no idea. You could tell me a little later. But it is a more very similar to the rotablation in the way that it does use the diamond, but it is a crown in the middle, and you could see it's a little eccentric. And by rotation, it rotates in two speeds, one at 80,000, one at 120,000. And the higher speed creates a bigger orbital round, so it makes the lumen much bigger in comparison to the 80,000. And you could see a very small surface, which is 10 micron of these diamonds. And again, very similar to the rotablation in a way, even when you handle it in terms of how you perform the procedure. But the difference in this is you have to go very slow and really take your time. And also you could do it antegrade as well as retrograde. So if you pass the lesion, you could always ablate the calcium going back. And this is quite helpful in kind of severe tortuosity of the vessel when there's a bend in the artery, or an osseal lesion if you're worried about dissecting the osseum into the aorta. So using the diamond back or the orbital atherectomy going backward is very helpful and really kind of overcome some of the limitation. And I say limitation because once you've had the experience with rotablation, I think you could do it in many situations. So this is the orbital atherectomy, and you could see that on the right side, the number of passes and also the speed that will allow you to increase the diameter that you obtain after the orbital atherectomy. If you look at the blue line, that's the rotablation. If you look at the yellow lines or the kind of greenish line, is the orbital atherectomy at different speed. You increase the speed, you achieve a bigger lumen. And of course, it's only one size, which 1.25 millimeter. That's all. Now coming to the excimer laser, very helpful and very good equipment to have. And again, I'm privileged to have had it for many years, and I do run courses and teach about this because it's a very valuable tool. It works by three mechanisms: photothermal, photomechanical, photochemical. The photothermal, there is a little bit of debate about this, but it does work, and it does increase the heat in the cells, so the water expands and rupture the cell vessel. This is a lesion modifying equipment rather than ablation. It does change the complexion of the lesion, makes it softer, and makes it easier to deal with after with balloons. Important thing to know that there are the 3 S's for using laser: using the saline flush, because if you keep it in contrast, you could create bubbles that can be problematic. However, once you have the experience, you can use the dye as a friend, because with these bubbles, it almost works like an IVL, causes a pressure on the artery up to 50 atmospheres. So if you use it in the right place, it can help you achieve success more. And you have to advance it very slowly, almost the same as the orbital atherectomy, to allow it to work on the tissue rather than just passing it up and down, because the lumen you will get if you pass it slow is quite important. And there are 4 sizes: 0.9 millimeter, 1.4, 1.7, and 2. The majority of the time, 0.9 is more than enough because it gives you the highest energy and the highest frequency. We have combined it with rotablation, where you use the laser first to create a channel to put the rotawire and get rid of the calcium, because laser is not the most effective in calcium, but nonetheless it can still be used at least to create a small channel for introducing the rotawire, which is a special really thin 10,000th of an inch to allow you to do rotablation. Laser grenade, as we said, grenadoplasty with laser, which is when you do the contrast, create these bubbles to create high pressure and affect the lesion. Cutting balloon, again, I don't want to preach to you about this. You've seen it. It's quite effective, but I don't use it very often. I only use cutting balloon now in two indication: instant restenosis, and when I'm doing a CTO or any other case and there's subintimal hematoma. Use the cutting balloon in these cases only. Otherwise, if for calcium, most of the time we revert to rotablation or orbital atherectomy or even laser. And as you could see here, the cutting balloon really minimizes vessel trauma, because the atherome, which is the same as really sharp, but you have to inflate it very slowly to allow the blade to open up. Once the blade opens up and you inflated the balloon, that's when you cut. And when the balloon is coming down for deflation, it's always recommended to move it back and forth gently, although we know that with the cardiac contraction, the balloon will move probably back and forth and create that cut. Angiosculpt, which is the scoring balloon. Again, the new version of the Angiosculpt has come out, and there's another one just being tried currently, just came out in the last 2-3 months. Similar kind of concept, but different way of putting the wires on to allow it to expand more. The Angiosculpt is semi-compliant with the external nitinol mesh, which eight wires, and that really scores in the artery. And I find it much more effective, albeit it is bulky to deliver, but it causes less dissection. And as you could see here, how it could score through the artery and breaks the calcium and allows you to, and fibrosis too, allows you to deliver your equipment and do a good procedure. These are the microcatheter I1 Turnus is not being used very often. It used to be 2.1, 2.6. And of course, we have the microcatheter all. The term by gold is quite a good, we call it like the poor man rotablation, although it's not cheap, to be honest. It's really expensive. But it does work, and we publish a series on this term by gold, effective in up to 72% of the cases. Again, when you're unable to deliver your balloon or unable to, and you haven't had a chance to put the rota wire down, or it's quite difficult, term by gold, which you could see it on the left there, it's almost like a screw. So once it gets hooked to the lesion and you rotate it clockwise, and it will advance slowly and create that little kind of cracks the lesion, then you could introduce the balloon. Again, I'll skip through this because these are just the term by catheters, and the term by gold on the top left is usually effective. So really, if you wanted to treat calcium, it's nice to have an equipment. I'm just going to show you this funny video, because if you have an equipment similar to this that you could do many things, that will always be very, very good. So I think you've seen all this Rota Bro, and I'm assuming, I understand that it is available also in Pakistan right now. It's being done, which is excellent. It has taken the foot pedal away, so it's all controlled with the hand on the table. And of course, the lithotripsy, which is a balloon. Usually it is with electricity, it changes the electricity into quite high pulses and create up to 60 to 100 atmosphere in the artery. You inflate it to 4 atmosphere and you deliver the pulses, 10 pulses every time. It used to be 80, and now, as I said, the new one has come out. It is 120 pulses, which is excellent because it does affect the calcium very well. It's very effective. The only caveat to this is the deliverability. And the second thing is, in eccentric calcium, I know there's a lot of noise and a lot of debate. Eccentric calcium, it is not as effective on occasion. It does work, but sometimes it might not be as effective. So it changes the vessel compliance, breaks the calcium, even the deep calcium, which is the advantage over rotablation or orbital atherectomy. Because sometimes if you have deep calcium, the orbital atherectomy or rotablation might not affect it. Lithotripsy does. And I'm just going to finish by showing you a case quickly. And before I tell you what I did, I'd be interested to hear what the discussion and see what people would think. So this was an 84-year-old lady who came to hospital 2 or 3 times, treated medically, has had previous bypass operation, comes back with good LV, comes back with multiple admission with ACS and anterior changes. A couple of colleagues did the angiogram, decided to treat medically because they thought it's too complex to intervene. She has a patent vein graft to the RV, to the right coronary artery, but occluded lima and occluded vein graft to the circ. Comes back on the 4th admission. I was on call, and then we took her to the lab, and this was her angiogram. You could see that there's a severe ostial LAD lesion. There's a mid severe LAD lesion, and that bend, I'm assuming maybe the bend or the lift from the lima connection. What would I be able to ask, or shall I just go and tell you what's been done? Would anybody like to comment how they approach this lesion or what they would do? Because you could see they have the calcium, which is typical after CABG.
You see over here that the biggest challenge is going to be at the point where there is that jump in the vessel also. And because you have your stitch placed over here, so this is going to be the biggest challenge, to put your stent over here and make it sure it goes up. And then there's another lesion after that also which has a bend. So there are plenty of bends going around. So probably what you would end up doing is having a stiffer wire or something like that, go through it. Once your channels are defined, I don't think as far as the proximal calcium is concerned, it's going to make much of a difference for your life. It's that little bit in between, that is the one which is the biggest challenge. For that, probably you'll end up doing some litho or something like that, because it's because of those angles and your hardware available to you. Probably that is the safer way, because these angles are not very good as far as rotational arthrectomies, which is our baby over here, is the thing to be used. And once you have your volumes well established, then probably you will consider coming back. That's my take on it.
Yeah. That's absolutely correct. I mean, when you look at this, heavily calcified, so I don't think you could do it just with balloon and stent. That's for sure, which is quite typical after any bypass operation. Depending on the experience with rotablation, yes, severe angulation can be very troublesome with rotablation, because you could easily perforate. It's not out of question, depending on your level of comfort and experience with rotablation. Orbital atherectomy here can be really effective. The only thing with the rotablation and with orbital atherectomy, they have a special wire. You have to deliver that wire before you're able to perform the rotablation or the orbital atherectomy. And of course, rota wire on its own will not go in here. So you have to use a microcatheter, going back to the discussion before, because again, an over-the-wire balloon, if it goes, then fine, you could do a balloon first and then reassess. But over the wire wouldn't go, and a screw-in microcatheter like Corsair or Turnpike LB would be helpful.
Yeah, but Egred, you can see a micro channel over there quite well, and it's probably that what you are going to aim for, and probably you have a good slippery stiff wire that will do the trick for you.
Yeah. So this is a hydrophilic wire all the way through, and this is what we. So this was a cyan black wire, and you could see that there's a microcatheter in the middle there, so it took a while to manage, because these two severe bends quite difficult. And after that, I decided to take a rota wire. Of course, you could see the rota wire did not advance very much. And of course, you have to be cautious when you're rotablating very close to the connection with the radioibic segment. But we did this very slowly. This is just a quick saved.
Which rota wire are you using, a 1.25 or a 1.5?
No, this is 1.25. The only time I don't use 1.25 very often. The only time I use 1.25 is severe angulation, if I'm worried about this, and in severe stenosis. Because in severe angulation is much safer to use the 1.25 and take your time and do it, so you don't cause any problem.
And for the audience, would you like to tell which wire you have? You have a hard rota wire or the flexi wire?
Right. So again, in 99% of the cases when I'm doing rotablation, I use the extra support. Except in cases like this where it's severe tortuosity, because you want to kind of lessen, to a certain degree, the bias of the wire. So in this case, I use a floppy wire. The majority, I said more than 98% of the cases I do, it's always with extra support. Because with the soft wire or the floppy wire, you have to be careful around bends, and you have to be careful around resistant lesion. If you've got the floppy wire and you're pushing with the burr, which you shouldn't, but sometimes with the resistant, the tendency is to try to push a little harder. The wire could bend and the burr will follow it and could perforate. In this case, I use a floppy wire, and you could use the 1.5, but you'll spend a longer time trying to burr, and the heat will be more, and the no flow could be more. It's better to start with a smaller burr with the severe narrowing and severe lesion, and then upgrade. And this is exactly what we did in here. Because as I said, the 1.5 will go, but eventually, but you'll have to spend much longer time, and you could cause more problem. So this was 1.25, and then I upgraded to 1.75, because the artery is big, and that you could see now it went without any issue. And that was, let me just, we ended up stenting the artery, and this was the final outcome. The lady was able to go home, and she was not admitted again to hospital, and did very well. So the point here is, like, if you feel like you need to use any calcium modification equipment, just use it, because quite often you get sucked in and you try to use a balloon and a wire and you spend an hour or two. And there was a case, actually, I should have shown this picture. I took it. Somebody was doing a case and it was a resistant lesion. 2 hours later and 23 balloons after, and the lesion still has not cracked. 23 balloons. So I think you could imagine how, so taking a rotawire, rotablating the lesion took about 5 minutes, and then everything was finished quickly. And I think with this, I'll just say thank you, and I'm more than happy to take any